So, quick reminder, people with epilepsy have seizures. Now, this may come across as a bit silly to say, but I bring this up to remind you that the workup for somebody with a breakthrough seizure who has epilepsy is actually pretty simple. Are they taking their meds? Are the blood levels of their medication appropriate? Do they have an infection that's lowering their seizure threshold? Or does this breakthrough seizure fall within their accepted seizure frequency? And that's pretty much it. Now the story gets a little bit different if somebody comes in with a seizure with no history of epilepsy, their first time seizure. That is when we really got to put our thinking caps on. I put my hood on instead of my thinking cap prop because I left that prop down in my car and it's all the way down those stairs, and I'm just not doing that for you guys. Sorry. Also, the sun just came out and it's like super hot on this, so for continuity I've left it on, but just between you and me, I'm dying. Welcome back to the channel, everyone. Today I'm going to be discussing the approach to the first-time seizure. This video is aimed at both new neurology residents and non-neurologists alike. This is because this is a very common presentation that PCPs, emergency department doctors, and internists are going to encounter, sometimes in situations where there are no neurologists available. Let's set the stage. So you're a newly minted neurology resident or even an emergency department doctor, and you just happen to not have access to a neurologist tonight. A 64-year-old man is brought in by his son after a witnessed spell of convulsive activity with associated loss of consciousness. The man is able to follow commands and answer some simple questions, but he just seems pretty groggy. Both he and his son deny a history of epilepsy or seizures. What do you do? Well, did he even have a seizure? People lose consciousness for a variety of reasons, and convulsive syncope is actually pretty common. So remember, not everything that shakes is a seizure, and it's your job to try to tease apart the difference. This is why we start with semiology. Semiology is simply the description of the convulsive event that may or may not be consistent with seizure. Now, we could spend a ton of time on the semiology of seizures, what represents seizure, what doesn't, but I'm going to save that for a video for another time. For this theoretical patient, we'll say that the descripted semiology is consistent with seizure. Now we're at the starting point, a first-time seizure workup. So what's the overarching approach here? I think it's important at this time to pause, back up, and define epilepsy. Technically, epilepsy has 3 definitions, but we'll really focus on the first 2. Definition A, at least 2 unprovoked seizures separated by at least 24 hours. Definition B, 1 unprovoked seizure and a probability of having recurrent seizures greater than or equal to 60% over the next 10 years. And C is a diagnosis of epilepsy syndrome. Now, we'll come back to that strange B definition, but what's the common tie between the first 2 definitions? It's that the seizures must be unprovoked. So this is the core of your approach to first-time seizure. Is it provoked or is it unprovoked? And this will guide your workup, which involves ruling out provokers. What provokes seizures? Well, I can think of 5 general categories that will really capture everything that can do this. Structural insults, infections, metabolic derangements, intoxication, and withdrawal states. So let's go through each one of those one by one, starting with structural insults. Maybe a tumor or a scar from an old stroke, maybe an intracerebral hemorrhage. While not necessarily associated with a structural component, I will put traumatic brain injury into this category as well. Next, we have infection, and common things we think of are things like meningitis or encephalitis, possibly an abscess, and even more systemic infections can potentially lower your threshold for having a seizure. Next, metabolic derangements. I remember that most of these are hypos because it lowers your level of consciousness, except for the last 2. So we have hyponatremia, hypoglycemia, hypocalcemia, hypomagnesemia, and then the last 2, uremia and hyperthyroidism. To be fair, on the extremes of hyperglycemia, you can have provoked seizures, but you really need to be careful here because someone, for example, with like smoldering diabetes or underlying diabetes that has a seizure, it will push up their glucose levels and sometimes push them into ketotic states. So was it the seizure or was it the glucose? which one came first, chicken or egg. Next, withdrawal. Common ones would be alcohol and benzodiazepines. And lastly, cocaine. These are going to be your stimulants like cocaine, amphetamines, and more generally medications that are associated with a lower seizure threshold. Now that we have a better understanding of all the possible provokers out there, this should really guide our workup. No workup is complete without a detailed history. And one thing I'd like to mention here is looking into seizure risk factors. That would include asking questions about prior head trauma, serious head trauma, prior stroke, a history of meningitis or encephalitis, a family history of seizures, or a history of childhood febrile seizures. Next, for the structural category, we'll obviously be using our exam to look for any focality. It'd be reasonable to consider deferring imaging if you come up with a very obvious source, such as alcohol withdrawal. In a person who's coming back to baseline and non-focal, you might be able to defer that imaging, but that's up to your clinical judgment. One little tangent here, just in general for neuroimaging, go with the best imaging you can depending on the situation. So what is a CT scan good for? It's good because it's fast and it picks up on acute blood. Barring a situation where the patient is in some kind of critical state, why not just get the best imaging if it's available to you? So go for the MRI. And thinking in advance, if you're gonna get an MRI, request it with an epilepsy protocol. Most radiology departments have this protocol, which basically uses very, very thin slices to look for things like gray matter heterotopia, and coronal slices to look for subtleties in the mesial temporal lobes. We'll come to that later. Next, infection. You're gonna obviously check their temperature, get a CBC. You'll have some information from the history about potential prodromal symptoms. Of note, the white blood cell count, lactate, and sometimes CPK will be very high just after a convulsive seizure. So be mindful that these will drop pretty quickly with time if you recheck, and to not forget about using your clinical judgment when you're thinking about infection. Next, metabolic. Essentially everything is captured in a complete metabolic panel. Withdrawal, this is going to be history from the patient or family, maybe getting a urine drug screen or an ethanol level. And then finally intoxication, again this would be a urine drug screen and a urine toxicology screen. Okay, so you did your workup and you didn't find any obvious provoker. Now what? Well, let's go back to that second strange definition of epilepsy. That was one unprovoked seizure and a probability of having recurrent seizures greater than or equal to 60% of the general population in about 10 years. What does it mean? How do I put a number value on someone's risk of recurrent unprovoked seizure in the next 10 years? Well, put very simply, you can get a general sense of this by looking for any structural or electrical abnormality that might raise someone's risk of having a recurrent unprovoked seizure. And this is why that second definition was added in 2014 by the International League of Epilepsy. It's to ensure that physicians don't forget about ordering that specialized MRI and EEG after a first-time unprovoked seizure, because if you find an abnormality, you can make the diagnosis earlier and start the patients on medication right away. So, if you have one unprovoked seizure and a structural abnormality on your MRI, like mesial temporal lobe sclerosis, or some gray matter or heterotopia, you have epilepsy. If you have one unprovoked seizure and an EEG that shows a higher seizure potential, you have epilepsy. So who gets meds? Well, certainly folks with epilepsy get anti-epileptic meds, and that's basically it. Generally, patients who are back to baseline, in which you have found an easily reversible provoker, don't need seizure meds. Now, certainly there's room for clinical reasoning and decision-making here, but that's the general rule. An example of this would be a patient who suffered a seizure due to hypoglycemia. That's a pretty easily reversible condition, and that person certainly doesn't need to go home on seizure medications. Now again, you have to use your clinical judgment. Say, for example, you have a patient with meningitis who's having seizures. The likely cause of the seizures is the meningitis, but that's not a condition you're going to quickly treat. So if they're clustering, having multiple seizures, or even going to status epilepticus, that's a person that you'd consider starting an anti-epileptic in, at least until you get the underlying problem sorted. So that's it. It's all pretty straightforward when you just consider, is this provoked or unprovoked? If you found this video helpful or in any way entertaining, please consider subscribing to my channel. It helps us a big deal. And certainly like and comment below. See you next time. Stop. Go away. No, this bird.